அந்த ஆளு 2 தையல் கொடுத்துருக்கோம். அந்த தையில பிரிச்சு விட வேண்டிதான்.
अच्छा, you are going to record it. अच्छा ठीक, ओके ठीक है.
Ma'am, will wait for some time. Am I audible?
Can you hear me?
Yes, ma'am.
Yeah. Clearly, na?
Ma'am, can we wait for? Hello. Yes, ma'am.
Yes. Hello. Hello. Yes, sir.
हाँ सेके दे मैं तो बाजू मुंह से रखूं हैं.
No, you unmute yourself. Unmute. Yeah, yeah, absolutely. I'll just put up the first line on it. Or you want me to do that also later? Huh? Okay. Yeah, this will do. Yeah, okay. Share के news में से बोल बोला था कहीं बुधवारी 7:30 येऊन ठेव. ठीक. असं व्हिडिओ नाही दाखवला तरी चालेल तसं.
हम्म. नाही तर म्हटलं असं हे काय आपलं बरोबर. ये इसमें है ना They're in the pocket.
Hello. Good evening, Dr. Bhagyashree Jabade. Am I audible to you? Hello. Hello.
Hello, can you hear me, Dr. Snehal?
Yes, ma'am, I can.
Yes.
Start or should we wait for another 5 minutes? Hello. Hello, ma'am.
Yes.
Ma'am, should we start or should we wait for another 5 minutes?
What's the time right now? It's 8:03, no?
Yes.
We'll wait for 2 minutes. 8:05 we will start.
Okay, sure, ma'am. Fine. Hello, ma'am. Should I start?
Yes, we'll start now.
Okay. Good evening, everyone. Welcome to today's webinar brought to you by the Indian Dental Association. We are delighted to have you all join us for this insightful session. Today's webinar aims to delve into the intricacies of periodontal health and management strategies. We hope that by the end of the session, you will have gained valuable insights into effective approaches for understanding and addressing periodontal pockets. Now, it gives me great pleasure to introduce our distinguished speaker for today's session, Dr. Bhagyashree Jabade. Dr. Bhagyashree is a renowned professional in the field of dentistry with over 25 years of experience. She currently serves as a reader, associate professor, and PG guide in the Department of Periodontology. She completed her BDS from Bharati Vidyapit Dental College and Hospital, Pune in 1996. She holds a master's degree in periodontology and implantology and a diploma in laser in dentistry from the International Society of Oral Laser Applications, University of Vienna. Currently, she is pursuing her PhD in periodontology from MUHS. Dr. Bhagyashree is widely recognized for her expertise in advanced laser and implant clinical practices, as well as her research contributions in periodontal diseases. Dr. Bhagyashree has made significant contributions to the field through her extensive research and numerous publications in peer-reviewed journals, including the International Journal of Photomedicine and Laser Surgery, the Journal of Periodontology. She has also held key roles in various professional organizations, such as serving on the executive committee of the Indian Dental Association and as a scientific committee member of the National Conference of the Indian Society of Periodontology. Please join me in welcoming Dr. Bhagyashree. We look forward to an engaging and informative session. I request all the participants to please put the speakers on mute since the question answer session will be held at the end of the webinar. Thank you. Over to you, Dr. Bhagyashree.
Thank you very much, Dr. Snehal, for giving me this opportunity, especially IDA. Now, good evening, everyone. As Dr. Snehal has said, my today's topic is a periodontal pocket. Now, IDEA has just started a very nice initiative, especially for the students. So, I'll be focusing this more for the undergraduate and the postgraduate. But even the treatment part, or if any doubts are there as a pointer from the clinician point of view, everyone is free to ask me questions. Thank you. So, today's our topic is a periodontal pocket. We will cover it under introduction, definition, classification, examination, clinical features, pathogenesis, histopathology, pocket contents, healing, prognosis, and the treatment part. Now, when we say a periodontal pocket, what it is? It is basically defined as a pathological deepened gingival sulcus. Now, here the pathological word is very important. The significance of this word, as we go ahead, you will come to know what is the importance of this word. This is one of the most important feature indicating the periodontal disease. Now, when we say deepened sulcus, what is a sulcus? Sulcus is nothing but a free space which is present around the tooth, which is normally around 1 to 3 millimeter. It is bounded on one side on the tooth surface and on other side on the free gingiva. So this deepening of the sulcus can occur as a result of coronal movement of gingival margin or apical displacement of the gingival attachment or combination of both. Now, as you can see in this diagram on the right side, there is an inflammation which you can see, the reddish zone. And that is the significance, what I was telling, the pathological deepening. That means it is not only the mere deepening of the sulcus, but some pathological or inflammatory changes has to be present. Now, they are classified as gingival pocket, periodontal pocket, or combined pocket. Now, as the name suggests, gingival pocket, it is also known as a pseudo pocket. So, as you all can see in figure 8, when the gingival margin moves coronally, leading to the deepening of the sulcus, it is known as a pseudo pocket. That means here the attached epithelium is intact. This is very commonly seen in cases of drug-induced gingival enlargement. Now, as you can see in figure B and C, when the deepening of the sulcus takes place because of the apical shift of the junctional epithelium, then it is known as a periodontal pocket, because this is the pocket is generally accompanied with destruction of the periodontal tissue. Now, depending on the base of the pocket, it is classified as suprabony pockets or infrabony pocket. When the base of the pocket is above the bone, crest of the bone, then it is known as a suprabony pocket. And infrabony pocket, as the name suggests, when the base of the pocket is below the crest of the bone, it is known as a infrabony pocket. Now, generally, the suprabony pockets are accompanied with the horizontal bone loss, while the infrabony pockets are generally accompanied with the angular, or what we call it as a vertical bone loss. Then, according to the number of surfaces involved, it might be simple when one tooth surface is involved. It might be compound when two or more surfaces are involved. In these cases, generally, the base of the defect is on one surface and then it directly communicates with the gingival margin. While complex type of pockets are the spiral type of pockets which originates on one tooth surface, twist around the tooth, they involve one or more additional surfaces and then they open on the free gingival margins. These are generally seen in the furcation areas, and these are little difficult to treat, and also the prognosis is little doubtful as compared to the simple and the compound type of pockets. Then, depending on the nature of the soft tissue wall, pockets can be classified as fibrotic pockets, which are seen very commonly in the smokers. As you can see in the diagram on the left side, there is a deepened sulcus. See, the probe is going deep. but see the tissues. While there may be a normal routinely what we see majority times is a edematous type of pocket. Depending on the disease activity, there might be active pockets or inactive pockets. Inactive pockets are the pockets where generally the healing is taking place. Now, the clinical signs and symptoms are in a strong correlation with the periodontal disease. So what the patient will show, the patient will come up with a either bluish red thickened marginal gingiva or full involving the attached gingiva. The gingiva will be shiny, puffy. Sometimes there may be suppurations present, tooth mobility, or there may be the diastema formation seen. While the symptoms the patient complains of majority time is the localized pain or sensation of pressure which subsides on its own. Foul taste, the patient will complain of mild pain radiating to the jaws. The patient will complain of urge to dig with some pointed instruments interdentally. There might be sensitivity to hot or cold, bleeding, and the patient will complain you of change in the position of the teeth, that is a gap formation. Now, how to examine the pockets? See, pockets is basically a soft tissue pathology. So they will not be detected on the radiographic examination. Only thing they will be visible on the radiographs when there is a bone loss which take place, either horizontal or vertical. So the most common method for exploration of the pocket is explore with the periodontal probe. These periodontal probes, there are different probes available in the market, like Markin's color-coded probe, UNC probe, UNC 15 probe, Williams graduated probe, Michigan O probe, and WHO probe. Out of this, the most commonly used probes are UNC 15 probe, which is shown in figure B, where you can see there are 15 markings are there from 1 to 15, and every 5, 10, and 15 band is darker. Next is figure C as it is shown, Williams graduated probe. This is another commonly used probe where the markings are from 1 to 10, and out of this 4 and 6 markings are missing. So these are the two probes which are commonly used. Now when we say pocket probing, there are two types of pocket depth are present. One is a biological or histological depth. This is the distance present between the gingival margin and the base of the pocket. That means the kernel end of the junctional epithelium. But is histological depth of the pocket depth we can see? No. This can be measured only by histological section. So routinely, clinically, when we want to do the probing depth, that is known as a clinical probing depth. So this is nothing but the distance between the free gingival margin and the base till the probe is getting inserted. That is known as a clinical probing depth. Now, there has to be a particular technique which has to be followed while doing this probing. This technique is known as walking the probe. That means the probe should be inserted parallel to the long axis of the tooth, and it is walked circumferentially. Walked means once you penetrate at the one point, you take it out, again insert it in at different point. That is known as a walking. You don't move it continuously through the margin. So it is moved or walked circumferentially around each surface to detect the areas of deepest penetration. That is known as a walking the probe. Now there is something called as a 6-point probing and 4-point probing. As you can see on the right side, imagine a tooth is divided into 6 surfaces. On the facial side, there will be midfacial, then mesiofacial, distofacial, and on the lingual side, there will be midlingual, mesolingual, and distolingual. So when the probe is inserted, suppose at distofacial, then you take it out, midfacial, again you record and take it out, again mesiofacial, and similarly on the other 3 sides, that is known as a 6-point probing. Or if another technique is only the probing measurement is done at the mesial side, distal side, and mid-buccal and mid-lingual. That is known as a 4-point probing. Now, whenever the probing depth is measured, the certain factors has to be considered and has to be taken care so as to give false readings. Like, for example, the size of the probe. The probe should not be too thick. Otherwise, the depth of the penetration will be more. Then the force. Imagine you are putting a lot of pressure to insert the probe. Automatically, the probe is going to get inserted deeper. And this will again give you a false reading. So the optimum force which has been recommended is around 25 gram or 0.75 Newton. Then direction of the penetration, as you can see in the figure, and as I've told before also, it should be inserted parallel vertically to the long axis of the tooth. Any angular penetration will cause more or inside exertion of the insertion of the probe. Next is resistance of the tissue and convexity of the crown. Now going to the pathogenesis, like how exactly this pocket formation takes place. Now before going to that, let's summarize briefly in short around the about the histology or the microstructure of the gingiva. You remember there is a sulcus which is lined by the sulcular epithelium, as you can see the figure on the left side. Then there is a junctional epithelium. The junctional epithelium is around 1.35 millimeter and it is tightly adherent to the tooth surface. This is the first line of barrier because the gingival sulcus is free. So all the food particles, it act as a free entry. So this has to be controlled somewhere. So there is a junctional epithelium. Below junctional epithelium, there is a connective tissue. This connective tissue again acts as a second strong barrier which prevent the spread of infection further. So if you can see in this figure, the alveolar bone, the body is created like the alveolar bone is protected maximum from the free entry of the food which is happening. Histologically, the junctional epithelium is around 15 to 20 cell layer thick. They are strongly adherent to each other by some cellular junction which is known as a desmosomes and to the tooth surface by the basal lamina. So now let's see how exactly this pocket formation take place. The main force or the main factors which are responsible for the pocket formation are the bacteria, and second is the behavior of host defense mechanism. Other few factors has also been recommended, like the characteristic of the invading flora, diet, pH, etc. But basically, the pocket reflects the sum total of responses of the host defense mechanism to the presence and activity of the bacteria. So whenever there is a pocket formation take place, the two processes occur. One is apical proliferation of the junctional epithelium with coronal detachment from the root surface, and second is the degeneration of the collagen fibers apical to the junctional epithelium. Now, always, as I said, the initiative force are the bacteria. So, where this bacteria comes from? So, these bacteria is basically, it comes from the plaque. So, initially, there is a supragingival plaque which develops and accumulates on the tooth surface. The bacteria which are present keep on releasing the toxins in the form of lipoxin, endotoxins. Now, whenever these toxins are released, as a body defense mechanisms, it attracts the inflammatory cells, because whenever any toxins are released, the body is going to fight against it. So these inflammatory cells get accumulated in the marginal gingiva. The whole occurrence of all this, what ultimately takes place is the gingiva get inflamed and it becomes edematous. Because if you can recollect the signs of inflammation, there is rubor, calor, dolor, tumor. So similarly, on the same basis, there is edematous, that means there is increased permeability as one of the sign of inflammation, correct? So the marginal gingiva gets inflamed and edematous, and this leads to the enlargement of gingiva, and the end result is gingival pocket or the pseudo pocket. This is the final response of the gingiva to the supragingival plaque. Now, if at this level, the supragingival plaque is removed, the patient is maintaining weight, or he goes to the dentist, get the scaling done, then again the gingiva goes back to normal and become a healthy gingiva. But if the plaque removal is not carried out, then this or the load of the bacteria is more, the plaque will extend now subgingivally. There are some environmental changes occur in the connective tissue and in the junctional epithelium. Now, as it goes subgingivally, the oxygen supply is going to reduce. So there will be more and more anaerobic and gram-positive microorganisms gather. They again release the toxins, but which are now subgingivally. And what is subgingivally present, as we have seen in the previous picture, is the junctional epithelium. And there is going to be a direct attack on the junctional epithelium. Now, as a host response to this, our first line of defense of the body, the neutrophils. The neutrophils come from the underlying connective tissue. They transmigrate through the junctional epithelium and they come into the sulcus. There they form a layer on the subgingival plaque and they try to stop the infection there or the destruction by the toxins, and they prevent its extension. As an inflammatory response to this junctional epithelium, it continues to migrate along the root and it gets separated from the root. Now, as you can see in this picture, there is a plaque which is present subgingivally. Over that, the neutrophils accumulate and they try to stop the infection over there. Now, this connective tissue, as my arrow is seen, basically where the blood vessels are present in the connective tissue. So, whenever the toxins are released in this area, this blood, the neutrophils from the blood in the connective tissue, they transmigrate through the junctional epithelium and they try their defense mechanism. As a defense mechanism, at the same time, they causes release of these certain cytokines. So that we will see ahead. So now these neutrophils which invade the coronal end of the junctional epithelium increase in the number. They release the cytokines and the MMPs. MMPs are matrix metalloproteinases. These are the enzymes which are released by all type of inflammatory cells, the neutrophils, the plasma cells, the macrophages. So release of these MMPs and cytokines takes place in abundance. Now, as I had told before, the epithelial cells are joined tightly to one another by desmosomes and by hemidesmosomes to the tooth surface via basal lamina. So these MMPs and cytokines, when they are acting against the bacteria, at the same time they attack the intercellular junction. So when this neutrophils volume reaches up to 60% or more in the junctional epithelium, the tissue loses its cohesiveness because all these cells, as I've said, they were initially joined by each other, but they get destructed. So the contact between them get broken. So the tissue loses its cohesiveness and it get detached ultimately from the tooth surface. And as a whole result of this is ultimately the coronal part of the junctional epithelium get detached from the root and the apical portion start migrating downwards. Now this is characterized because of the degeneration or necrosis of the junctional epithelium. And the end result is the apical shift of the junctional epithelium. Now, the next step is the degeneration of the collagen fibers. Now, as I've shown in the previous picture, there is a junctional epithelium and below that the second line of defense is the connective tissue fibers. So, all these collagen fibers are generally tightly adhered so that they prevent the junctional epithelium from migrating apically. So, when the junctional epithelium want to migrate apically, there has to be some space. Now this space is taken place by degeneration of collagen fibers. Now how does this degeneration takes place? One is directly because of the toxins. Okay, they cause directly the collagen destruction. And second is the host response. Now, as I've told before, as an inflammatory response to these toxins, the neutrophils, the fibroblasts, the macrophages all get accumulated in the connective tissue. They get activated. They release these matrix metalloproteinases like collagenase and other enzymes. And these enzymes destroy the collagen and the extracellular matrix. At the same time, the fibroblasts which are present, they also get activated. They destroy the collagen fibrils which are present or inserted into the periodontal ligament. They have been inserted. You remember these collagen fibrils are inserted into the periodontal ligament from the bone to the tooth surface. So that connection get destroyed by the fibroblasts. And the end result of this is the whole degeneration of the collagen fiber. So now the junctional epithelium gets free space here apically to move down. And so ultimately the end result of all this is apical shift of the junctional epithelium, destruction of the collagen fibers, and when it reaches the bone, the osteoclast get activated and the bone loss starts. So if you see the summary of this pocket formation, there is normally first start with the supragingival plaque. When this plaque will extend subgingivally, the neutrophils will act. They will attack the pocket epithelium. The pocket epithelium might get ulcerated. And ultimately, there is a coronal detachment and apical migration of the junctional epithelium with periodontal pocket establishment. So this in short, histologically what you can see. So in the figure B, you can see the plaque or the calculus which is present, and so the junctional epithelium is detached. Always remember, junctional epithelium never gets completely separated. It gets detached, but somewhere at the base, it is attached to the tooth surface. Now, what we will see histopathologically? Histopathologically, basically the changes are seen in the soft tissue wall and in the root surface. When we say a soft tissue wall, again it will be in the form of pocket epithelium and connective tissue. So, as we have said that the cells of junctional epithelium normally derive their nutrition from underlying connective tissue. The connective tissue has got a blood supply. So, change in the pH of the environment, because of the change in the pH, this junctional epithelium is deprived of the nutrition and slowly start degenerative changes. Initially, this starts in the superficial layers, that means the layers which are closer to the tooth surface. Histologically, as the inflammation increases, the junctional epithelium will start proliferating. Because of this proliferation, they show long finger-like projections. Ultimately, the epithelium becomes thin, and sometimes these projections become so long that the epithelium breaks its continuity with the ulcer formation. So it is been seen in the histological studies or under the electron microscope that epithelium, the length, what I told you, is around 0.75 to 1.35 millimeter. It get reduced only to 50 to 100 micrometer. Now, because of these inflammatory changes in the connective tissue, there is a detachment of the principal fibers, and ultimately the epithelium proliferates down over the cementum. Now, what happens in the connective tissue? The connective tissue, as I have told you, the signs of inflammation, it becomes edematous, it get infiltrated because of the plasma cells, get infiltrated with the lymphocyte, few neutrophils. The blood vessels are increased in number, they are dilated, they are engorged, and the connective tissue also starts showing some degree of degeneration and single or multiple necrotic foci. Microtopographically, that means under the electron microscope, starting from the junctional epithelium near the tooth surface towards the connective tissue, there are different zones are seen, like areas of relative quiescence, means dead and inactive cell layer, which is towards the tooth surface. Then below that, there is areas of bacterial accumulation. The bacteria are seen in between the cells. Then there are areas of emergence of leukocyte as a host defense mechanism. The leukocytes start accumulating in the intercellular spaces. Then areas of leukocyte which are present in the bacterial interaction. Areas of intense epithelial desquamation, that means the cells are loosened, and areas of ulceration because there is a break in the continuity with connective tissue exposure, and areas of hemorrhage. Why? What is seen on the root surface wall? On the root surface wall, the cementum undergoes structural, chemical, and cytotoxic changes. The Sharpie's fibers which are present in the cementum undergo degeneration. You can see pathological granules are observed. Bacterial products like endotoxins have also been found in cementum. The cementum gets softened. In few cases, the viable bacteria has been found on the root surface. Some bacterial penetration has been seen in the cementum up to the dentinal tubules. The diseased root fragments prevent in vitro attachment of the gingival fibroblast. That means all about changes which are seen in the cementum. So when they have done in vitro studies, they found that such type of root fragment prevent the attachment of gingival fibroblast. And that is why when we say that there is scaling and root planing, so root planing is done so as to remove this disease cementum. That is the significance of root planing. And ultimately there is a softening of the cementum surface which might get exposed to the oral cavity and exposing the dentinal tubules, and sometimes the patient might get complaints of sensitivity. It is because of this. So when we see the surface morphology on the tooth side, it will show as a calculus covered by around attached plaque. Then there will be a unattached plaque, junctional epithelium, partially lysed connective tissue fibers, and below there will be intact connective tissue fibers. Now overall seeing, so now correlating all this pathology or this mechanism of action or whatever the changes which are taking in the cementum, these are correlated with the histological presentation. Now for example, what I've explained you before, there is increased blood vessels, engorgement. All this circulatory stagnation is responsible for causing the pocket to become bluish red, or the gingiva become reddish blue, or more of bluish. Second, there will be bleeding on probing is increased. That is because of the vascularity is increased, thinning and degeneration of epithelium. Then as I said, there is increased permeability causing edema, and because of this edema there is pitting on pressure. Then the destruction of the gingival fibers in the connective tissue is taking place. So normally how gingiva is firm and fibrotic, but in disease state it becomes soft, smooth with shiny surface. Now fibrotic changes sometimes as a repair if the bacterial load is less, if the healing take place, and so the gingival will look more fibrotic. Why? The epithelial changes which are indicating of the ulceration of the pocket wall. Because of this ulceration, there is pain on probing. And sometimes if the inflammatory response of the body is suppurative, then there will be a pus formation seen into the gingiva or abscess formation. Sometimes, as I've told, that these microorganisms can spread either through the dentinal tubules or from the apical foramen to the pulp, and the pulp changes also start showing some degenerative changes, and that is why there is sometimes is a sensitivity or what we called as a endoperio problems. So it can give rise to, if it is not controlled well, can also give rise to endoperio problems. So what does this pocket contains? It consists of the debris in the form of microorganisms and their products, gingival fluid, fluid remnants, salivary mucin, desquamated epithelial cells, leukocyte, and purulent exudates in the form of living or degenerated necrotic leukocytes, bacteria, and some amount of fibrin. Now, how the healing of the periodontal pocket takes place. So when we say healing, the most important factor is remove the local irritants like plaque and calculus. So as soon as they are removed, it allows the healing because the host defense repair is continuously under process. So the healing will depend on the bacterial load versus the host defense mechanism. So if the host defense activity is sufficient, the anti-inflammatory cytokines will predominate and the gingiva will look pink and fibrotic. On the other hand, if the bacterial load predominate, then the pro-inflammatory cytokines will predominate in the pocket wall and the pocket wall will look like more of red and inflamed. Now, what is the prognosis of the periodontal pocket? Overall, the periodontal pocket, the prognosis is good, but there are certain factors which determine the prognosis, like pocket depth, how much of the loss of attachment has taken place, how much of the bone loss has taken place, and the type of the pocket. Now, coming to the treatment part of the periodontal pocket, main aim of the pocket therapy is remove the local irritant, which is most commonly is the plaque and calculus. Once that is removed, second is eliminate the pocket depth, try to eliminate the pocket depth completely or at least reduce it. Alteration of the soft and the hard tissue to get a proper topography and a plaque-free status should be created, which will be easily maintainable by the patient. So, what are the criteria for selection of treatment? Overall, in the 1999 classification and 2017 classification, it is classified as mild periodontitis, moderate, and severe. So it is observed that when the pockets are less than 4 mm deep, see, when, as we have seen before, the normal sulcus depth is 1 to 3 mm. So above 3 mm depth plus the pathological changes which are seen, then it is known as a pocket. So when the pockets are present between around 3 to 4 mm, that is indicating of mild periodontitis, and such pockets can be just treated by good scaling root planing and giving proper oral hygiene instructions. In cases of moderate periodontitis, when the pockets are present between 4 to 6 mm, first step, as I said, is remove the local irritant. So scaling root planing has to be carried out. Those pockets, after scaling root planing, allow the tissues to heal, and those pockets which remains there and which are extending beyond 5 mm will only go for flap surgeries. And third is severe periodontitis, when the pockets are either 7 mm or deep. In such cases, flap surgery is mandatory because there is no access through scaling root planing, and flap surgery is a choice of treatment. Now, in cases of intra-bony pocket, that means when the base of the pocket is below the crest of the bone, there will be the treatment of choice is nothing but a flap surgery, because accessibility to the bone will not be achieved by only doing scaling root planing. So the full thickness flap is a flap of choice. Now these bony defects can be then eliminated either by osseous resective surgery or osseous regenerative technique, where use of bone grafts or membranes is recommended. So the pocket therapy, if you see, it will be divided into mild pocket, moderate, or deep pocket. So if the probing depth is roughly around 3 to 4 mm, the treatment of choice will be scaling root planing, and along with that, local drug delivery use of different local drugs, laser pocket sterilization. In the moderate pockets, like the probing depth is when between 5 to 6 millimeters, then flap surgery is indicated, and the deep pockets when the probing depth is 6 millimeter or more, and along with the flap surgery, regenerative procedures are recommended. So to conclude, understanding the etiopathogenesis, histopathology, and progression of the periodontal pocket is essential to provide the patient a successful treatment outcome. And ultimately, our aim of the treatment should be that create an environment which will be easily maintainable by the patient. Thank you. If anyone has a doubts, questions,
Yes,
you have
ma'am.
feel free to
I
ask.
request all the participants to please put your questions one by one. I request all the participants to please put up your questions.
I think it was so self-explanatory that no one has doubts.
Yes, ma'am. I think it's really good.
Okay, fine. One more thing I would like to tell everyone that there are certain questions which is come now, as Dr. Snehal said, it is basically because of the for the student education program. So there are certain questions which has been come commonly into the university exams. So you can jot it down. So you can prepare it accordingly. One is define pocket, classify, and methods of pocket elimination, correlation of clinical and histopathological features of periodontal pockets, root surface changes in periodontal pockets, microscopic features of gingival wall in the healthy gingiva and in the pocket, and the pathogenesis of periodontal pocket.
Ma'am, we have one question.
Yes.
What is treatment of pocket in menopausal women, diabetic women?
See, basically, when we say a diabetic patient or menopausal patient, the basic treatment of the pocket remains the same. Now, there are two different factors. One is menopause, one is diabetes. When you say menopause, it is being seen in the evidences have shown that in the menopause, they are more prone to the bone loss. So, in such patient, routine checkups, routine scaling root planing, and routine what you call maintenance of the oral hygiene is the utmost important. Second, considering the second part is the diabetic patient. In the diabetic patient, you know the effect on the classification 1999 and 2070. There's a strong correlation, periomedicine, systemic diseases, and the gingiva. So like that, diabetes has a strong effect on the periodontal disease. It accelerates the periodontal disease destruction. So first of all, whenever a diabetic patient is there, first factor is to check whether the diabetes is under control. Second, the treatment plan. If the patient, such patient has got a periodontitis or the pockets, first, second, once the sugar checkup is done, then next part is thorough scaling root planing. And third part, generally the diabetic patients are more prone to show gingival enlargement. So if there is a bone loss or after scaling root planing, if the pocket persists beyond 5 millimeter, flap surgery is indicated and give proper oral hygiene instructions.
Ma'am, the next question is perioendo lesion, roots of a lesion and treatment.
Endoperiolesion lesion. Okay, fine. When we say endoperiolesion lesion, as I've said, the periodontal infection can either go through into the pulp via dentinal tubules or to the apical foramen. Now, when we say endoperiolesion lesion, they are classified as purely perio, purely endo, or to start with endo and then going into perio, and fourth is start with perio and going into endo. Now, I'm not going into details about the endoperio because as it is a different full topic. But when the periodontal infection from the pocket goes into the pulp, typically what you will see that the tooth will start showing severe pain, severe sensitivity without any presence of cavities. The tooth is healthy, there is no cavity present, but the pocket is present and there are deep or there is sometimes accompanied with the bone loss. In such cases, first treatment is do a flap surgery if the pocket is more than 5 mm, okay, and avoid doing the root canal. But if there is a periapical thickening of the lamina dura is seen in the radiograph, then you have to carry out intentional root canal. Because of the intentional root canal, the whole pulp will be blocked because of the obturation, gutta-pacha points. Once that is done, then the second part will be flap open karke, then you have to do a thorough debridement.
Okay, ma'am, next question is just a minute. How to manage gingival and periodontal disease in specially abled patients?
See, basic treatment plan remains the same. Like for example, first you have to carry out the phase 1 therapy, the scaling, root planing. Now, when it is specially able children are there, only thing is giving the proper instructions, because those patients generally don't follow the proper oral hygiene instruction. So in such cases, the ultrasonic or the power toothbrushes are recommended. If the patient is or the child is very uncooperative, then the scaling, even the basic scaling root planing can be carried out under conscious sedation, which is more safer. So the basic treatment plan always remains the same. Only thing, the oral hygiene care has to be utmost important in those patients. We should be taken care by giving normal ultrasonic toothbrushes and or there are power toothbrushes.
Okay. Thank you, ma'am. Next question is periodontal disease in pregnant women.
Yes, periodontal disease in pregnant women. Now, generally, these diseases are in correlation because of the hormonal changes. So, they are generally now pregnant women. So, generally, in such case, again, you have to see whether it is a gingival disease or the periodontal. The pregnancy tumor or the pregnancy epilis or pregnancy gingivitis is very common. So, if the inflammation is only limited to gingiva, scaling root planing can be carried out without any hesitation, very safely, and give proper instructions to the patient to maintain the oral hygiene, because such patients has to take extra care for the oral hygiene as compared to the normal patients. That is first. Second thing, now, if the gingival enlargement is more, or if you imagine a pregnant woman is coming with the deep pockets where the surgery is indicated, then surgery can be carried out safely in the first trimester. Avoid second trimester, avoid first trimester and third trimester, because in the first trimester generally the organogenesis is taking place, while the last trimester, third trimester, first of all, it is very uncomfortable for the patient, and never work in the supine position. There is a premature delivery chances are there. So generally second trimester is safer, and it can be carried out under the antibiotics, but only a few antibiotics which are safer to use in pregnancy. but giving the oral hygiene instructions and proper maintenance of oral hygiene to these patients can avoid these problems.
Ma'am, we have one more question. One patient, he asked that one patient had come to me with gingival pain with no sign of any gingival inflammation and tooth decay, but history of abrupt brushing. How to diagnose it?
Sorry, one patient came with a, I think it is there, एक minute,
Yeah, yes, ma'am.
Uh, So one patient had come to me with gingival pain with no signs of gingival inflammation and the tooth decay, but history of abrupt brushing or it's abrupt bleeding. See, first of all, the bleeding can take place either because of the trauma. So if the patient is having a hard brushing or the hard bristle brush, it can lead to gingival bleeding. Second is there is a gingival pain might occur because of the gingivitis, or you can take up a radiograph, and OPG is the best, which is indicator if any bone loss is there. If that is the situation, then you have to treat that patient as a periodontal disease patient.
I have other questions coming up.
Yeah, no problem.
Ma'am, should I say?
Yes.
Yeah. How does estrogen levels affect in menopausal women and its effects on periodontium?
I think I've told you before that the estrogen levels, these patients are more prone to have a gingival inflammation. The evidence and research has shown that osteoporosis, and there is a strong correlation between osteoporosis and periodontal diseases. Okay, so such patients are more prone to gingival inflammation, at the same time bone loss. Okay, so if the patient has to get regularly checked up the calcium levels, fine, and the basic maintenance of hygiene and the basic treatment. If there is no inflammation or there is no as such problem is present to the patient, maintenance of oral hygiene is sufficient. If the patient is prone for more bone loss, then if required, a flap surgery to remove the local irritants is required.
Thank you, ma'am. Next question, treatment for gingival irritation without any clinical signs present.
Gingival irritation without any clinical signs.
Yes,
See,
ma'am.
gingival irritation, again, it might be either because of any local factor, plaque calculus, or sometimes any overhanging restoration. So first and foremost important is you have to find the cause, or sometimes there may be allergy. In the 1919 classification, they have given a long correlation that or long list of factors where the local irritants or sometimes even the allergy is responsible for causing gingival pain. So first of all, find the cause, and then that has to be treated first.
Next question is, how does the depth and morphology of periodontal pockets affect the prognosis and choice of treatment modalities?
Yeah, as I've told you, if you see, go back to the last slide, the depth and the morphology. Depth means the depth, the pocket, if there are mild, they are falling into mild, moderate, severe. So as I said, 1 to 3 millimeter is a normal sulcus depth. If it is beyond that, like 3 to 4 millimeter probing depth, where we can carry out only scaling root planing and maintain the oral hygiene, no surgery strictly, between around 5 to 6 mm. If the pockets go beyond 6 millimeter, then is the flap surgery, and deeper pockets which are 6 millimeter and more has to definitely go for the flap surgery treatments. So your choice of modality, treatment modality, as Dr. Richa, will depend upon how much is the depth of the pocket.
And we have many questions coming up.
Okay.
Yeah, what medicines can we give to a pregnant woman with pockets?
The medications, there are amoxicillin has proven to be safer. Only avoid tetracyclines or the metronidazole has to be avoided. But otherwise, the basic antibiotics like amoxicillin is safe. And any NSAIDs are also being proven safer in the pregnant woman.
This question is various methods of PDL reconstructions.
Various methods of periodontal reconstruction. See, again, this is a different topic. It comes under regenerative therapy. So when we say periodontal reconstruction, that means the bone reconstruction will be because of the grafts and membrane. So I think Dr. Snehal, you have to arrange a new different seminar for this because it's a whole different topic as together.
Yes, ma'am, sure. Ma'am, next question is something about desquamative gingivitis.
Yes. Desquamative gingivitis is a type of inflammation which is generally because of either any allergies or basically it is a autoimmune disease. So in these cases, generally the topical steroid application is the best treatment. And if those patients, if there is a severe inflammation which is present, or if they are not responding to the topical, then the steroids, giving systemic steroid is the treatment of choice. So when we say desquamative gingivitis, generally it is seen, it is in more of a postmenopausal female and 40 years and above. It has a strong correlation with the stress factor. Okay, so and the treatment of choice is topical or systemic steroids.
Next question we have from Dr. Richa. What are the implications of biofilm resistance in periodontal pockets for antibiotic therapy, and how can this be addressed in clinical practice?
See, frankly speaking, Dr. Richa, now it has been proven by the position papers and the reviews that antibiotics is not a treatment of choice for chronic periodontitis. But only if the surgeries are carried out, then the systemic antibiotics are prescribed just as for safety, because sometimes the patient's response or the patient's is as a safety side for the infection, so the antibiotics are prescribed. Otherwise, the antibiotics should not be given only to the chronic periodontitis cases or only if the pockets are present. There are only few proven conditions where the antibiotics are prescribed. Like for example, abscess, pericoronitis, aggressive periodontitis. These are the cases only where the antibiotics has been advised to be used.
Next is laser effective in treating periodontal pocket?
Yes, as I have put it in the last slide, there is something called as a laser pocket sterilization. Now, this is carried out in the mild type of a periodontitis when the pockets are present around 3 to 4 millimeter. So, there are mild pockets where the surgery has to be avoided. Then, in such cases, laser application is safely carried out, and that is known as a laser pocket sterilization. The advantages of the laser is not only it helps to remove the debris or the curettage, but along with that, the laser has a bactericidal effect. But deeper pocket, whenever flap is exposed, even yes, laser can be used for because of its bactericidal activity.
Ma'am, we have one question. How can amlodipine affect gingival enlargement can be treated?
Yeah, amlodipine, see, when any patients, now see, as you know, the drug-induced gingival enlargement is common. So if the patient is giving you a history of taking such medications and you are seeing the gingival enlargement in such patient, first and foremost is write down, refer the patient to the physician, okay? Ask for replacement of the drug. There are now new drugs are there which are equally effective and without any harmful effect on the gingiva. Then second, as we said, phase 1 therapy. See, remember, any disease, any periodontal disease, any gingival disease, there has to be a first phase is phase 1, that is scaling root planing. Scaling root planing thoroughly has to be carried out. Then wait for 3 weeks. After 3 weeks, again recall the patient. Once the local irritants are removed, because see, in the drug-induced gingival enlargement, there is like a vicious cycle. Because of the drugs, the enlargement takes place. Because of the enlarged gingiva, they are more prone to accumulate plaque and calculus. More accumulation, more inflammatory response, and there is a vicious cycle. So once the scaling root planing is done, if the alternative drug is prescribed by the physician, well and good. If it is not possible, then depending upon the how much of the enlargement is there, your treatment plan will be. So after 3 to 4 weeks, if the mild enlargement is there, it goes back, very good. No treatment to be done, only maintenance. While if the enlargement is more or it persists, then you have to go for either gingivectomy or flap surgery.
Ma'am, we have last 3 questions. Treatment of aggressive periodontitis.
Okay. Aggressive periodontitis is a type of a periodontitis where there is a severe bone loss and at the faster speed. So generally the prognosis in such cases is not very good. And the worst thing about aggressive periodontitis is at early age. So as you know, the prognosis is not so good. But again, the choice of treatment is the flap surgeries and reconstructive therapy. That means the bone grafts, because aggressive periodontitis is typically characterized by vertical type of defect. So bone graft, use of membranes and reconstructive therapy is the choice of treatment. And if there is a severe bone loss which is present, grade 3 mobility, which cannot be saved, then the choice is extraction and implantation or putting the implants. And evidences have proved that the implants are successful in such patients.
Ma'am, next question is, can laser be used in pregnancy in second trimester for pockets?
Definitely. Laser is very safe. It can be used definitely in pregnancy. And actually, if you see, the lasers are best rather than avoiding a surgery. Some cases where there is a more gingival enlargement is present. The patient is pregnant. So you cannot carry out the flap surgery. So by doing a repeated laser therapies, and the laser, which will cause a laser pocket sterilization, and it can be maintained till the delivery occurs, and then post delivery the surgery can be carried out. So the lasers are best and safe in pregnancy.
Next question, what should be prescribed if patient shows excessive bleeding post scaling? Can we prescribe vitamin C?
Yes, vitamin C will not help in reducing bleeding. See, as I have explained you before, why the bleeding takes place during scaling is because the gingiva is inflamed. There is high amount of inflammation, and that's why the excessive bleeding occurs. So if you carry out a good scaling, thorough scaling, bleeding will stop on its own. No need to worry. So vitamin C, yes, vitamin C can be given, but that is just at the safety procedure. It will not have any extra effect on bleeding or controlling the bleeding. Okay. If there is a bleeding which is because of any systemic disease present, that has to be taken care, like by using certain drugs or hemostatic agents. But for that, again, a thorough systemic history is very important.
Ma'am, just one last question. How can periodontal pockets be effectively managed in patients with compromised immune systems, such as those with HIV or undergoing chemotherapy?
Yes, HIV patient, again as I said, scaling has to be carried out by using proper protocol. There are the kits which are present that has to be used, proper disinfection. Those undergoing chemotherapy, yes, again the scaling and the surgeries can be carried out, but under the antibiotic cover. In these cases, a proper thorough antibiotic cover has to be carried out, plus physician's consent. Okay, and again, laser in such cases of medically compromised patients is again a very good tool so as to control the pockets and the infection.
I guess there are no more questions coming up, ma'am.
Okay.
So, I would like to really thank you for taking the time to share your expertise and insights in the webinar on periodontal health. Ma'am, your presentation was incredibly enlightening and engaging, and your valuable knowledge and perspective will definitely and undoubtedly benefit all the participants, ma'am. Thank you so much once again for such an informative session.
Thank you, IDA, and thank you all the participants. And my contact number is there. I'm there on the Insta also. If you have any doubts, I carry out laser workshops, periodontal workshops also. If any doubts are there, feel free to ask me. Thank you so much.
Yes, thank you, ma'am. Thank you all the participants. Thank you, ma'am. I'll end the session now. Hello.
I'll just take a screenshot, then we'll end.
Okay,
Can you
sure,
put
ma'am.
on your video?
Ma'am, right now. Try. Ma'am, I'm actually at my home, so.
Yes. Thank you so much, Dr. Snehal, and thank you for troubling you.
No, it's fine, ma'am. Thank you.
Okay. Looking forward for your the next education program.
Yes, thank you so much. Same here, ma'am.
Thank you. Thank you so much.
Thank you. Ma'am, off the session now?
Yes, sure.
Okay, thank you.